Hello and welcome back. Today we'll be starting with the scalp. So the scalp is made out of 5 layers, and the word scalp is actually a mnemonic. So the first layer is the skin, the second would be the connective tissue, third is aponeurosis, then the loose areolar connective tissue, and then the periosteum, scalp. So the first 3 layers are strongly bonded and they act as one unit, so the scalp can't be folded. The top layer, the skin, is where the cysts form because there are sebaceous and sweat glands. Cysts are an infection caused by either a minor trauma or an ingrown hair, and an infection forms and the body sequesters it and isolates it, forming a painful lump that is full of pus. Connective tissue layer is fibrofatty and it contains septa, which are tough collagenous fibers, and it's highly vascular. Aponeuroses are thin tendinous sheets, and it unites the occipital and frontal belly of the occipitofrontalis muscle. There you go. Right here in the middle, that is the aponeurosis. And the lateral margins of the aponeurosis are also attached to the temporalis fascia. So hematomas in the connective tissue layer are contained and they don't spread because of the septa. As you can see, this poor kid, it's very defined, right? There it is. The hematoma forms because the septa don't allow the vessels to constrict. So the blood will just pool, but it won't spread. So the next type of hematoma is in the subaponeurotic space. In other places they call it the subgaleal. And the loose areolar in this layer loosely connects the epicranial aponeurosis to the periosteum, so it has very few small arteries and emissary veins. And since it's loosely connected, the hematoma and an infection called the phlegmona can spread because there aren't any septa. Degloving is a type of injury where it is an open damage of the 3 outer layers, and the tone of the occipitofrontalis muscle leads to the spreading of the edges of the wound. There's a risk of hypovolemia, hypotension, and death because this is a very vascular area. You lose quite a bit of blood. So to prevent that from happening, the best way is to apply pressure and create a tourniquet. So a tourniquet can be like a shoelace or a belt or a tie, but you have to tie it above the ears very tightly. So the pericranium is attached tightly only at the suture, so the subperiosteal hematomas can spread within the boundaries of the bone. So here's a comparison of all of the different hematomas. So this is the subdural hematoma, so it's under the dura, and this is going to be the subgaleal or the subaponeurosis hemorrhage. So you can see how it spreads. There you go. It's not quite as bounded. And this is the subperiosteal hematoma. See how it ends right at the suture. And right here, this would be the most superficial hematoma. So in the connective tissue layer. So it is bounded tightly because of the septa. And you can see the septa right here. Here we go. So emissary veins, they will drain the scalp and the bone. And the parietal emissary veins connect the superior sagittal sinus to the superficial temporal vein. The occipital emissary connects the transverse sinus and confluence sinum to the occipital vein. The condylar emissary connect the sigmoid sinus to the deep cervical vein and the external vertebral venous plexus. And then the mastoid Emissary will connect the sigmoid sinus to the occipital and posterior orbicular vein. So there are these four plexuses: the internal carotid, foramen ovale, hypoglossal canal, and foramen lacerum are the main plexuses. Plexus just means like a confluence of veins. And infection of the scalp, if spread, if infected in the veins and the plexuses, most particularly the plexuses, they can spread very quickly and cause osteomyelitis, because look how much they infiltrate the bone and the brain itself, right? So infected blood in the diploic vein may travel deeper and make the venous sinus thrombosis. Let's see how everything is connected here. So the face, it has the sweat and sebaceous glands. So that's why, when we get sweaty, we see perspiration on the forehead, on the upper lip. It is connected to the bone by loose connective tissue, which the muscles of facial expression is embedded in. And in people with particularly round faces and in babies, they have a well-defined buccal fat pad of Bichat. Here you go. See? And gives them the little pudgy face. There are no deep fascia in the face, and the Langer's line and the Kressel's line correspond to the natural orientation of the collagen fibers. So if you want to be a surgeon and you want to promote good wound healing, you want a good approximation of the incision, you want to cut along the natural orientation of the collagen fibers, because it will heal much faster and much better. Not a main reason to do it, but an added benefit is that it will reduce the amount of scarring. So here are the facial muscles. They arise from the bone and insert directly into the skin. So their functions are either sphincters or dilators. That's their main function. Their secondary function is to modify facial expression. All the muscles of the face are developed from the second pharyngeal arch in development. And they're all innervated by the facial cranial nerve, so cranial nerve number 7. The Occipitofrontalis is made out of 4 thin muscular quadrilateral parts. So there's going to be the two occipital parts, and then the 2 frontal parts, and in between is connected by the epicranial aponeurosis. So the occipital parts arise from the tendinous fibers from the lateral 2/3 of the superior nuchal line and the mastoid, and it extends forward and joins the aponeurosis, which joins the frontalis. The frontalis doesn't actually have a bony attachment, it just continues. Those fibers blend with the procerus, the corrugator, the supercilii, and the orbicularis oculi muscle, and they ascend to join the epicranial aponeurosis in front of the suture. So these fibers run that way, and these fibers run that way. They're used to raise your eyebrows and to some people can feel it and some people can't, but like move the scalp. So the circumorbital oculi, and those include the orbital muscles, lacrimal, palpebral parts, and the small ciliary bundles. Those are like right here. They're fine fibers close to the margin behind the eyelid. And all of these kind of involve opening and moving the eye. The corrugator supercilii right here, as you can see, furrows the brow, and the levator palpebrae superioris raises the eyebrows. Some people have a very well-defined the levator palpebrae or like occipitofrontalis in one area and not the other. So that's why some people are able to raise their right eyebrow but not their left, and vice versa. And then some people aren't able to raise like one eyebrow at all. The nasal muscles, there's the procerus and the nasalis transverse. It will compress the nose, so when you take a deep breath in, you know how like the nose will like narrow, and the alar muscle will flare the nostrils. The depressor septi may be absent. It's just a muscle right here. Some people are able to curl their lips. Some people can't. These muscles in the nose are involved in respiration and facial expression. And in people who have like cleft lip deformities, these muscles, especially along the top lip, may be absent. So the elevators, retractors, and evertors of the upper lip are the levator labii superioris, the aliscae nasi, the levator labii superioris, the zygomatic major and minor, and the levator anguli oris, and the risorius. And then the depressors are the retractors and evertors of the lower lip. They would be the depressor labii inferioris, depressor anguli oris, and the mentalis. They altogether they work as a compound sphincter and form the orbicularis oris and the incisivus superior and inferior. Here's the incisivus superior, inferior. All of these allow us to purse our lips and open our mouth and smile. What to note is the muscles of the upper lip. They will desiccate with the muscles of the lower lip. So upper lip will go down and go that way, while the lower lip muscles will go up and then that way. So the Buccinator the origin are the alveolar margins along the teeth and the pterygomandibular ligament. The fibers face forward, insert around the mouth, at the angle of the mouth. As I described before, the fibers will desiccate, and this is the one muscle in the face that has the fascia called the buccopharyngeal fascia, and the Buccinator is used to suck in the cheeks. So here it is. It's a big muscle. And these are the movements of the face, as you can see. You can raise your brow, furrow them, contract the muscles up here, wink, flare your nose, puff out your cheeks, raise your lip, that's a smile, to curl the lip, to purse the lips over here, the frown, and this is the protraction. This is, pouting, and this is a muscle that doesn't really involve the face. It actually involves this muscle in the neck, the sternocleidomastoid. Okay, so these are the muscles for mastication. That's the temporal muscle, the masseter, the lateral and medial pterygoid, which are deep to the mandible. The temporalis is covered by the temporalis fascia, which forms the aponeurotic sheath. The masseter is thick and tendon-like. There you go. And it connects to the zygomatic. Deeper, smaller muscles, and more muscular, and that one connects to the mandible. So this is the deep part. The medial pterygoid, superficial head, is from the lateral pterygoid plate, like on the skull, and the deep portion originates from the maxillary tuberosity and the pyramidal process. So here we go. The lateral pterygoid, that's right here. Medial is right here, and the inferior inserts on the condylar process, while the superior inserts into the articular disc and the fibrous capsule of the temporomandibular joint. They're bounded by the lateral pterygoid superior origin, which is the infratemporal surface and the intratemporal crest of the greater wing of the sphenoid. So the temporal mandibular joint is synovial. So it has articular biconcave fibrocartilaginous disc in between. Here you go. Unlike the other articular surfaces, this is covered with fibrocartilage, not hyaline cartilage. And the ligaments are the lateral temporomandibular ligament, the sphenomandibular, and the styloid mandibular ligaments. And those all kind of play a role in stabilizing the jaw and to protect the external ear. So the dislocations is usually like, when the mandible is depressed, a patient will come in unable to close his or her jaw, and their lower lip will protrude quite far. This usually happens because of a blow to the chin or a contraction of the lateral pterygoid. Some people with a congenital defect where the fossa and the condyle doesn't fit right, if they yawn, it can dislocate easily. So look here. Here is the mandible, and it should be fitting all the way up here. All the way up here. And here it is. I remember what muscles are involved by lame. So if you say la, that would be the lateral pterygoid involved to open the jaw. And when you say me or lame, your jaw will elevate to close, and that would be the medial pterygoid. So in order to reduce, you, the clinician, will put your fingers in patient's mouth, avoid the teeth. You will not put your thumb between the teeth, but you will put your thumb between the lips and the outer gingiva, and move the jaw down and then back up in like a scooping motion in order to reduce the dislocation. That's it for now. Thank you for your attention, and good luck studying.